Welcome to the second day of the Kendon Smith lecture series on childhood social anxiety, bridging developmental and clinical perspectives. Before I introduce our schedule for today, I'd like to thank the Kendon Smith Lecture Series Committee and all those individual faculty members who have been so helpful and with all the arrangements. And also my whole research lab has really pitched in to help with this, so I'd like to thank all of you as well. Today we have our last two speakers, and we'll have a coffee break in between their two talks, just as we did yesterday. And then at the end, we're going to have a roundtable discussion amongst the speakers. First, the speakers will be discussing some of these issues amongst themselves, and then we'll open it up again to the audience. Our first speaker today is Dr. Dina Hirschfeld-Becker. Dr. Becker is Director of High-Risk Studies and Anxiety Research in the Clinical and Research Program in Pediatric Pharmacology at Massachusetts General Hospital and Associate Professor in the Department of Psychiatry at Harvard Medical School. Dr. Hirschfeld-Becker's work focuses on examining risk factors for psychiatric disorders in young children and designing preventative interventions. As co-investigator for an NIMH-funded longitudinal study, now in its 15th year, she has been studying predictors of childhood anxiety disorders, including behavioral inhibition, family genetic factors, and family environmental factors. And as an outgrowth of this work, she developed and is testing the first manualized cognitive behavioral early intervention for anxiety in 4 to 7-year-old children. Please welcome Dr. Hirschfeld-Becker.
From the beginning. Great.
Great. Thank you very much. I really want to thank Heidi for organizing this symposium. This is really great. I'm delighted and somewhat humbled to be here. And I work at as Heidi said, I'm a clinical psychologist in a teaching hospital. And so we think of things in clinical terms, and we talk to psychiatrists a lot, and we use DSM-4 a lot. And so we start out with thinking about what's the disorder that we really want to try to do something about, and in our case we try to think about what disorders we want to try to prevent and how we can try to identify risk factors and try to do things to help children early so that they don't suffer long or over their lifespan from these disorders if we can help it. So just to give you a little bit of background about social phobia, it's a common, debilitating, and persistent disorder. The estimated lifetime prevalence, at least in Western countries, is from 7 to 12%. Lifetime means across the lifespan, children and adults. There have been few epidemiologic studies that actually look at rates in prepubertal children, but the point estimates are about 1%. And the estimated 12-month or point prevalences in adolescents are 3 to 4.4%. Just for those of you who may not be clinicians, the diagnostic criteria in DSM-4 for social phobia are that a person has to have marked and persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar peers or possible scrutiny by others. So for children, they sometimes just show a fear of unfamiliar peers. For older children and for adults, they also can articulate that what they're afraid of is scrutiny by others, of becoming humiliated or embarrassed. The second criterion is that exposure to the feared situation almost invariably provokes anxiety. Now, in adults and older children, they can tell you that they're anxious. In very young children, you sometimes see tantrums, shrinking, freezing, that anxiety is manifested behaviorally. For adults, they need to recognize that the fear is unreasonable. Children don't need to. the feared situations have to be avoided or endured with intense anxiety and distress. And it also has to cause interference to the person's regular tasks. So for a child, it needs to interfere with social development or with academic performance. For adults, it may interfere with relationships, with occupational functioning, or the person has to really experience a lot of distress. And again, for kids, it needs to last at least 6 months, and they also have to have good capacity for age-appropriate relationships with familiar peers. Now, DSM-4 allows for a couple of subtypes. There's really no agreement on how to classify these, but discrete social phobia is a fear of one or a few social or performance situations, which may be things like speaking or writing or eating or performing in front of others. And generalized social phobia is thought to be a fear of a broader range of social situations. The mean age of onset of social phobia that we see in adults is mid-adolescence, but generalized social phobia begins earlier and is a little bit rarer. It makes up about a third of cases. So the mean age of onset in one study for generalized was around age 10, and for discrete social phobia was older in adolescence. And it has a somewhat uneven gender ratio in the community, but in clinical samples it's about even who comes in for treatment. In childhood social phobia, what we see is crying, clinging, freezing tantrums, or excessive timidity in unfamiliar social situations. And these kids tend to avoid extracurricular activities or any kind of activity where they need to be with a group. So you see them avoiding things like sports teams and choosing solitary activities. There's school refusal in a minority of children. These are kids who don't like being invited to birthday parties. 75% of those who present clinically in one sample reported no or few friends. And they tend to underestimate their social skills, if not to really have poorer social skills. It's debilitating because it can cause social and academic dysfunction, as we said. There have also been studies that anxiety disorders in general in childhood lead to lower self-esteem, sometimes lead to victimization by peers. In adolescence, social phobia leads to broader avoidance and more social isolation. And the studies, the epidemiologic studies that look at impairment in adulthood find impaired role functioning and work productivity, reduced educational achievement, impaired social and romantic relationships, and also strong risk for subsequent disorders, particularly major depressive disorder and substance abuse. So in addition, social phobia tends to be persistent. And I think Ron Rapay alluded to this yesterday, that it's one of the most persistent anxiety disorders over time. And the studies that look prospectively find high persistence of social phobia from childhood to adolescence, from adolescence to adulthood, and across adulthood. And many of these studies look at current diagnosis at one time and find that it predicts the current diagnosis at a later time. So if it's not clear persistence all along, it's at least recurrent episodes. And the studies of adulthood don't necessarily find the person meeting full diagnostic criteria across all of adulthood, but they may lose a few symptoms so they're not meeting criteria, but always have some level of residual symptoms and impairment. And a retrospective study done at our center suggests that suggests that in adults with social phobia, earlier onset or presence of childhood anxiety disorders is associated with a more severe and comorbid clinical presentation. So one argument for early intervention, besides the obvious argument that if children are in distress, it makes sense to try to take care of them as soon as possible, is that this could also affect the child across the lifespan, that the continuity of social phobia and of anxiety disorders in general may reflect constitutional proneness to anxiety across development. They may have genetic factors that cause them to be at risk for anxiety across development. And it's also the case that children who develop maladaptive strategies for coping with anxiety, for example, avoidance, might use those same strategies to cope with anxiety the next time it comes up for them during their life, and that could lead them to exacerbated dysfunction. So improving skills for coping with anxiety early may mitigate the severity of future disorders, and of course it could also help reduce the acute distress that the child's experiencing.